Okay, so I think we'll start. Welcome to everyone. Thank you for joining if you're in the Northeast on this cold Wednesday. My name is Beth McAvee. I am one of the partner physicians at RMA of New York. And RMA is a very large, well-known fertility center in New York. We are based, we sort of like to think of ourselves in all of New York. So we're based in Westchester and in Brooklyn and in Manhattan and in Long Island. So we have 4 labs. We have physicians in multiple offices in the locations. We are the practice of, that's affiliated with the Mount Sinai Hospital System, again, in New York City and in Long Island. And so we train fellows, we have a fellowship program. We're all double board certified in traditional OBGYN, and then of course in reproductive endocrinology and infertility. So I am happy to see you. I'm happy for you to see one of the other physicians in any of the other practices. And so at the conclusion of today, if anyone on this meeting would like to have an evaluation of their own reproductive potential and consider maybe egg freezing or any other type of treatment, definitely reach out. You can email or call the offices or email me directly. Or email, I believe, the marketing team that had set this up to begin with. So you'll keep us posted, whether it's now or in the future. But anyway, it's nice to meet all of you. Sometimes this is a first conversation for some patients. Sometimes they've listened to this multiple times and just trying to gather more information. Everyone has their own story. In terms of egg freezing, it's something we've done for many years, for decades, really. I would say historically, it was for patients who were given an unfortunate diagnosis of cancer, and prior to undergoing treatment that would render them infertile, they would go through a stimulation to try and preserve their fertility. I would say the shift towards that to what we see now, which is patients that maybe are not in the position in the next, either now or in the near future to attempt to be pregnant, and they're nervous that if they let it go on, into their mid 30s or late 30s or even into their 40s, that they may have trouble. We see couples that are unsure if they want to have children in the future, but again, want to leave all doors open and don't necessarily want to create embryos. So, different situations, but this concept of preserving fertility, which was called elective, and I would say most of my colleagues don't really believe it's elective. We actually think it's necessary. But this idea of doing fertility preservation in the non-cancer setting, has really become the majority of the patients that we're seeing, I guess, thankfully, right? We don't want patients to have cancer diagnoses, but and I would say there's a few reasons why that has happened. One is just social awareness, referrals from OBGYNs, everyone having more awareness of, okay, let me check my reproductive potential and see where I am, and having more knowledge about the aging process and how females are built differently than biological men. And really probably the change in technology that took place about a decade ago that has led to very high egg thaw survival. So taking a frozen egg and thawing it, that technology that went into effect about 10 to 12 years ago and is commonplace and standard now, has led to very high thaw survivals, which is why we meaning the industry, is very comfortable at using frozen eggs to create embryos, and even most of IVF, which is in vitro fertilization, taking an egg and fertilizing it. Most of IVF in today's day is using frozen embryos. So the change in technology, and I would say awareness, is really what has spurred this concept of, well, if I'm not looking to get pregnant now or soon, maybe I should, fertility preserve myself at the youngest possible age. And so that's kind of the history of it. The biggest question that I get often is, can I get pregnant? Or, what I want to, like patients come in, I want to know if I'm able to get pregnant. And it's a question that really cannot be answered unless somebody was attempting to be pregnant, which the inability to conceive is what is called infertility. There's no way to predict fertility. And so that is the challenge. There's no crystal ball. And again, and I go back to that, if someone is not trying to conceive soon and they're in their 30s and they might want more than one kid, then yes, perhaps the patient should do a fertility preservation process, which typically is egg freezing if they're single female. And so that's the challenge. We can't predict infertility, or we can't predict the ability to conceive or inability to conceive. And so, given the age of the female, a lot of patients will make this decision to, okay, since I don't know, let me take things, control the situation, take things into my own hands and do something that's proactive and will serve me perhaps better down the road. So this idea of egg freezing is what it is. It's extracting eggs to freeze so that if a patient had infertility in the future, we have younger eggs available to go through IVF, in vitro fertilize, take a sperm and fertilize an egg. And the beauty of this technology is that regardless of the age when you use the eggs, so you could be 44 years old, the success rate is based on the age at the time of freeze. And so that is why this process is quite remarkable. Women are built differently. Biological females are built differently than biological men. So biological females are born with a finite number of eggs. We hit our reproductive potential, which starts honestly with onset of period or onset of menses, and you go through your teens and your 20s and your 30s, and the same thing happens to all females. We lose eggs every month until there are none remaining, and that's called menopause. Menopause is no more eggs. But we're all, sort of in a slope of some sort. Some people are, less of a slope, and some are steeper. And so part of the evaluation of a female is, what is the egg count or the follicle count at a given moment in time. So when patients come into the office to see me or one of the other physicians, we typically will do two things. One is an ultrasound to look at the ovaries and look at the follicle count. The follicle count represents the egg count. They're visualized areas on the ovaries. Again, menopausal follicle counts are 0. An average follicle count for a 35-year-old is probably around 12, if I could say that. And again, as you get older, it goes down. There's no way to regenerate eggs. There's no way to make new eggs or make new follicles, whereas biological men regenerate sperm endlessly. And that's why older men can impregnate, or have sperm available to potentially impregnate or to use for fertility treatment, as old as they can be. They could be in their 70s or their 80s. There's always sperm available in some sense. The quality is a different story, but they have sperm. For a biological female, that is not the case. And so eventually we get to a point in our 40s where we have exhausted all eggs, and it is extremely difficult to get pregnant. Miscarriage rate goes up. And so that is why, the earlier you are at time of an egg freeze, the better the chance those eggs, if they needed to be used in the future, would be able to be fertilized, create embryos that can give way to a live birth, a healthy live birth, a healthy baby. And that's the whole point of doing this. So, when you come into the office, you'll have an ultrasound. We'll look at the ovaries, look at the follicle count. There's also a blood test called anti-Müllerian hormone. It's a marker of egg quantity. There are age-specific averages for AMH levels. Menopausal AMH is 0. Or less than 0.1. And so the younger you are, typically the higher the AMH, and then again, sort of goes down and correlates with antral follicle count or egg count. So the ultrasound is a very good modality. It's a very good tool to give the patient an idea as to how many eggs we think they'll get at time of an egg retrieval. It can vary month to month, but typically it is fairly consistent, on a month-to-month basis. So I think it's important for, anyone listening to this, for any female, maybe a minimum, just go and have an ultrasound or ask your OBGYN to run an AMH. Sometimes the OB does do the AMH level in the blood, in their annual visit, and then it ends up being lower than it should. And then they get referred, and then we do egg freezing. But sometimes, the opposite is also important to think about. Let's say you did the AMH and it's high, that actually gives a reason to egg freeze. Freeze when you can just do one retrieval and get as many eggs as you possibly can. So it's once and done, and then you sort of live your life more free. But anyway, so that is an important part of reproductive evaluation. Patients often ask, how many eggs should I freeze? It's age-based. So the younger you are at time, of extracting or freezing, in theory, the less you need, and the older you are, the more you need. There's been tools that have been created. There's online, egg calculator tools, based on female age at time of freezing. I would say a 30-year-old probably needs somewhere between 10 and 15, and a 40-year-old probably needs somewhere between 20 and 30. The challenge we sometimes face is that, not every patient who's going through an extraction process is going to get 20 eggs at a retrieval. Sometimes they do, and that's great, it's once, but often they don't. And if that's the case, then sometimes they need to go through another retrieval. So again, that initial ultrasound and initial AMH level that's drawn will definitely help guide the patient and the doctor in terms of what the expectation is for egg freeze number and how many times we think that they need to do it. I guess if I could give one criticism of egg freezing, and it's just, being very honest, which is important, you cannot test eggs. We don't know if what we freeze for the patient is going to thaw, fertilize, and make an embryo. There's no way to tell by looking at it. We can say, okay, you froze 15 eggs, we feel great about it, but we don't know if those eggs are going to make healthy embryos, and we don't know if the healthy embryos are going to work. Most of the healthy embryos work, not 100%, but there's very high implantation rates on created embryos. And so because we can't test the eggs, we do compensate with quantity. So again, the more that we create, the more that we extract and freeze, at the time of the extraction, the better the chance we'll make embryos in the future. So all of that is tailored conversation based on the individual patient, based on the individual age, the desired number of kids. Some patients come in and they're one of 4 siblings, and their life dream is to have 4 kids. Okay, it's a different situation. You should freeze more up front. Some folks, just want 1 child, and that's great, and that's fine. And so again, you want to use age of the female, the AMH level, their antral follicle count, their desired family size, in terms of guiding how many we think we want you to freeze. So it's individual approach for sure. We, when the patient comes in, besides doing the AMH level and the ultrasound, we typically will check a thyroid screen, we'll check sugar, levels, we'll look at the height and the weight. We'll look at past medical history. Are there any medications that the female is on that she should come off of before egg freezing? Surgical history as well. So, a full history for the patient, and again, do the ultrasound. So in terms of the logistics, typically you need somewhere between 12 and 14 days, more often 12, from start to finish. So it's not that long of a duration. You will get very specific instructions. Most centers use a platform that teaches the patient how to self-administer the medication. So the medications are a class of medications called gonadotropins. Typically, they are injectable meds. It's a subcutaneous small injection that you learn how to self-administer, and you essentially are injecting what's called FSH and LH, so follicle stimulating hormone and luteinizing hormone. These are naturally occurring hormones that we have that tell our ovaries to ovulate every month. We're just giving it to you, and you're giving it to yourself in pharmaceutical doses. And the idea is, in a natural cycle, the female ovulates 1 egg. We want you to almost ovulate whatever you can give, 8 or 10 or 12 or 15, whatever it is, whatever your maximum potential is. But before they're released, we go in very timed, very specifically timed with a vaginal sonogram, and it's a vaginal sonogram, ultrasound guided egg extraction. So it's all done from below. There are no incisions on the abdomen. It's quick, 10-minute procedure. you're taking the medications on average for about 10 days. And the procedure itself is relatively quick. Most centers in RMA, definitely gives IV sedation for extracting eggs. There is an IV place, there is an anesthesiologist with you. You're not, intubated or paralyzed. It's in kind of a twilight sleep, but there is sedation given so that you are comfortable and you don't have pain. The injections, like I said, are self-administered in the skin, typically morning and night, so twice a day. And during that time frame of taking the medications, you do visit the office in the morning for ultrasound and blood work. And the point of those visits is to watch the follicles grow. So we do ultrasound, looking at the ovaries, looking at the follicles, and then we also do blood work. The blood work tracks your hormone levels. As follicles grow, they are more noticeable in ultrasound, they get larger, and the estrogen levels go up, and we track both. And then when certain parameters are met, typically size of the follicle and the number, the quantity, we say, okay, great, she's ready for the she's ready for the egg extraction. And that's when we time very specifically when to do this. So it's 2 weeks from start to finish. I will tell you, I have been a fertility doctor since 2009. So I'm getting up there in terms of my years. 95%, maybe more, of patients say it was not as bad as I thought it was, meaning it was easy. Most patients actually feel really good on the medications because of the estrogen elevations. They kind of feel actually a little bit elated, I guess is the term I would use. So most patients feel actually quite good on the medications. The biggest complaint is a physical bloating. If you are somebody that is a very good responder and you have a lot of potential follicles that are growing, your body feels it, right? You feel that the ovaries are larger and you feel bloating and you feel pressure in the belt, in the abdomen, and you can have cramping. That's the biggest complaint. The injections typically are without issues. Some patients can have little injection site, maybe redness, but very limiting in terms of the severity of that. Post egg retrieval, again, the biggest complaint is cramping. Really, that's what it comes down to. But I would say the more you have, the more you cramp. It's a good thing. Hopefully then it's just one retrieval and then we're done. 99% of patients do not need more than Tylenol or Advil post-extraction. And then patients will get a period 1 week after they have the retrieval and they're seriously back to normal. If you were on a birth control pill before, you can restart the birth control a week later. And then it kind of just, you kind of just go back to your normal life. You would assess how many were extracted, how many were frozen, and then make a decision. Are we happy, or do we feel like, we need to maybe do one more retrieval? Not that we have to do it that month. You could, rest for a month or two, and then you can make a decision. So, that's kind of the lay and the landscape. If you have an IUD in the uterus, it can stay. That does not need to come out. If you were on a birth control beforehand, you can stay on the birth control pill up until start of the extraction. And then again, when you bleed after you retrieve, you can restart it. Those are sort of the two biggest questions that we often get asked. In terms of embryology, so, the intention of doing this is to get as many mature eggs as possible to freeze, because only mature eggs are typically are competent to then be frozen and fertilized in the future. Not every egg will be mature at time of extraction. Most of them will be, but not all of them. And so on day of the extraction, you will know, okay, I extracted 12 eggs, and then you'll know the following day, out of those 12, 10 were mature and frozen. RMA, traditionally, if an egg is extracted and it is not mature, we don't just discard it that day. We will mature it in the dish. It's called in vivo maturation or in vitro maturation, during the day and then even overnight. And if it matures the following day, it does get frozen and it's, just as competent to be utilized in the future. So I just give you that little bit, because sometimes patients go through and, they get 15 extracted and they only freeze 12, and they were wondering why. But so those eggs are frozen really forever. There's no expiration in terms of their use. They have very high thaw survivals, typically, above 90% of the frozen eggs will thaw survive. Because they are frozen eggs, you have to do IVF going forward. So you have to pick up where you left off. They have to be thawed, they have to be fertilized in the dish. And then we see how many embryos are created from the fertilized eggs. And then we plan for an embryo transfer. You won't know what you have until you go to use them. So again, it's important to figure out age of the female at time of doing this, desired family size, and then of course assessing how you did in that extraction time point. How many did we extract and freeze? So I think for anyone that's on this call, if you're a friend, whatever, anyone that's thinking about it, maybe make an appointment, do an ultrasound, see what the follicle count is, do an AMH, see where you are age-wise, and then make a decision. I mean, I always say no one is ever regretful of having eggs. The biggest thing I see in my practice is people my age, mid-40s, who did not do this 10 years ago or 8 years ago or 12 years ago. We weren't doing it in the rates, the time that the way that we're doing it now. And so now the patients in their mid-40s are really struggling a bit because they don't have anything to fall back on. Not that it's a guarantee, it's really not. It's not people say, oh, I'm doing it as an insurance policy. It's really not, but it gives you more options, to potentially have a biological child. And so the ladies in their mid-40s really at this point, if they did not freeze eggs previously and they've gone through traditional treatment now, unfortunately, unsuccessfully, what are we doing? We're doing egg donor. And I bring that up because, egg donor IVF is using frozen donor eggs. So it's the same process. It's just that these are, frozen eggs from younger females, but they're frozen, they're extracted in the same way, they're frozen in the same way. And again, these frozen donor eggs thaw, fertilize, and make embryos, and are allowing patients who did not previously fertility preserve to go forward and have have children. And so the technology is very good. It is not changing anytime, I don't think ever, to be honest with you. And so I do think it's a very good time for patients to consider doing. Egg freezing is FDA approved. It's not experimental. There are a lot of insurance companies that are now covering egg freezing. So that is something else I, really encourage anyone on this call to consider. We have a whole team of finance, insurance coordinators that will go through your insurance plan. If you're in a New York State, there are a lot of insurances that are covering. And then beyond that, there's a lot of employers that are now offering fertility benefits for patients. So there's something called Maven, there's Carrot, there's Progeny. So these are kind of, fertility perks or benefits that are sort of given to the employee in addition to their health insurance. And then again, there are some health insurance companies that are covering, specifically Cigna is a very good one, and NYSHIP, New York State, New York State employees. So whatever you're, regardless, the consultation is typically covered by almost all insurance companies. If you don't have insurance, then we figure out the best way for you to navigate it. The medications that you take for this process, if they're, if it's covered by the insurance, will come from pharmaceutical companies that, coordinate with your insurance company. If you don't have insurance coverage, then our finance teams and our cycle coordinators know where to guide you to get the cheapest deal. The bottom line is it's all the same med. We just try to get you the cheapest price in terms of the medications. The medications do come from specialty pharmacies, and they do get, directly ordered and mailed to you with delivery. And then again, you will get a link to a portal that shows you how to self-administer the medications. All consent forms for this process are done electronically. So, just like everything I would say now, in modern day, a lot of it's done remote. So, consents and all the ordering, you'll have access to a fertility care coordinator or a cycle coordinator that really is your go-to person that you could email all day and, help you sort of get yourself set up. And that's it. I mean, I think it's a very good thing to consider doing. I always tell patients, for me, it's a no-brainer. If you're in your 30s and you're someone that's thinking about doing it, you're not planning to be pregnant soon, you'll never be regretful of doing it. I think the biggest hurdle for a lot of patients is if the insurance doesn't cover, can they navigate the costs? That you have to personally make a decision on. But I do think it's a very good thing for patients to consider doing. And again, really can set you up to have so many more options, going forward in the future in the event that you have, infertility. What else I want to tell you? I think that's it. Let me see what's on the queue. Oh, BMI for the process. So every fertility center has their own BMI cutoff, not for the actual procedure. It's really for the anesthetic. So New York State certifies surgery centers based on BMI. So on Long Island, our BMI cutoff is 45. So BMI is body mass index. It's weight as a function of height. So on Long Island, it's 45. I believe for Manhattan, because of the setup with the anesthesiologist, it is 40. I think Brooklyn is 40. I'm not sure what Westchester is. So Long Island's 45, and then New York City is 40. So I always tell people, if you feel like you're above the 40 and you live in the city, I could see you. You can extract out here. And we can actually remote monitor you in the city. That's the other thing I do want to emphasize. For all the RMA practices, you can monitor, like if you live in Westchester, but you're in the city twice a week for work, but you live in Westchester and you want to retrieve with Jeff Klein, retrieve with Jeff, and you can monitor in the city twice a week. It's not a big deal. We'll send all, you can go to any office for ultrasound and blood work. Same for me. If your BMI is 43, you can't safely extract in the city. I can extract you on the island, you can monitor in the city. So you'll keep us posted. We do whatever we need to do to help the patient. So that one we talked about. Okay, you mentioned getting blood test sonograms during the 10-day period of taking medication. How often? Yeah, so in the beginning, it's every 3 days. So you typically start, 3 days later, you come in for blood and ultrasound. And then typically it's 2 days later, and then 2 days later, and then you're kind of ready. So I would say you budget 5 ultrasound and blood visits within the 10-day time span. The best way to view the ovaries is vaginal. With that being said, we have many patients that have not, had intercourse before, or they have difficulty having, having ultrasounds or pap smears. So I've had many patients that we just do belly scans. So we do abdominal scans. It's not a big deal. We just scan you the whole time that way, and we do blood work to track. Obviously, day of the procedure, you're going to have sedation, and that will be a vaginal sonogram. You have to extract eggs vaginally. But if you want to have abdominal sonograms done, I'm very comfortable to do that, and I'm sure the other doctors in the practice are. So that's not a big deal. The blood work does have to be done in the morning. The office is open very early. So again, depending on where you live, the Manhattan offices, I think most of them open at 7. I think it's 7 o'clock for the start. Long Island, we actually have 2 offices one opens at 6:15 and one at 6:30, because sometimes the Long Island patients need to go to work in the city. So we try to accommodate, but we could give you, depending on where you live, we could give you a list of the offices and what time they open. I have a lot of teacher patients. So my teachers typically go to our Great Lake Success Great Neck office, because it opens at 6:15, and then they can get to work by 7:30. But it does need to be done in the morning, because then we get the results back, and then we call you in the afternoon to say, okay, stay on your same dose of medication, and we'll see you back on Friday. So that's why the bloods do have to be done in the morning. The eggs stay frozen forever. There's no expiration date. Honestly, there isn't. We're using eggs decades old at this point. You do get storage fees. Long Island charges monthly. I feel like the city is doing, I don't want to misspeak. I don't know if it's every 3 months or every 6 months, but they're doing it, might be quarterly, like every 3 months. But yes, you do end up paying some insurance. If your insurance is paying, some insurance companies do pay. If you do not have insurance and you are paying, out of your pocket to do this, I do believe the storage is included for the first year. And then again, the finance coordinators can give you pricing on that. But yeah, it's either monthly or quarterly that you will get billed. So, and obviously patients actually who don't get the bill, they're always like, I didn't get my bill, I'm like, I promise the eggs are here. But no, for us, we send it monthly, but I think the city is quarterly. But there is no expiration. And again, when you go to use that, if you needed to use, meaning you were given a diagnosis of infertility, which hopefully none of you would have, but let's say you did, and your insurance did not pay for egg freezing. Most insurances, I would say 80% of commercial insurances cover fertility treatment, meaning the use of the egg. So although maybe you didn't have coverage for egg freezing, 80% of the time they will pay for you to use the egg, which is IVF, right? Taking it, thawing it, fertilizing it, making an embryo, and doing an embryo transfer. Vast majority of the time, most of that's covered. So, right. So this is someone, one of the attendees wrote this. I considered egg freezing a few years ago, and insurance would only cover it, right, in the case of a severe medical necessity. Elective egg freezing was not covered. Has that changed? It's employer dependent. So it's all based on your employer. Historically, medical necessity means cancer diagnosis, or sometimes diagnosis of endometriosis has worked, or somebody that's planning to have surgery. So you can, there's ways to sort of, tweak things a bit, but if your insurance requires authorization and they don't cover, again, they use this word elective, which drives us crazy because we don't, as fertility doctors, we don't think it's elective. We think it's actually necessary, but it's employer-based. So I can't answer that. It's based on your own employer, but we will always, we'll do a verification of your benefits before you come in. And then obviously when you're here, I would say employers have sort of changed a bit though. Like the hospital systems in New York are now covering egg freezing. So NYU, Sinai, Stony Brook, Northwell. I don't know about Northwell, but at least Stony Brook, Sinai, and NYU are paying for egg freezing. The big box companies, Amazon, Costco, just Target, they cover egg freezing. Cigna typically covers egg freezing. So you have to, we'll qualify it, but there has been a shift to have more coverage for sure, without question. The patient comes in like every 2 to 3 days during that 10 to 12 day time span. It's not every day, but every few days you come in for blood work and ultrasound. So I say budget a 2-week time span where you're here. Again, if you're someone that lives in Westchester, lives on Long Island, and wants has to go to the city, it's not a big deal. Or you live in Brooklyn, but the BMI is over 40 and you want to extract on Long Island, it's we can play around with it. Someone wrote here, how many times can someone do IVF? An extraction. That's a hard question. I think it depends on number of eggs extracted, what the situation is, age of the female. There isn't necessarily a limit. There's no cutoff. But I think it depends on what's happening. If the patient is, has gone through many times, sometimes we go to plan B if it's not working, but that would be individual conversation. In terms of activity during the 2 weeks, when you initially start, you can kind of live your life normally. At the end, if you're a big exerciser, you wouldn't be exercising, the day before the retrieval. As the ovaries get big, we worry that they can twist. That's called an ovarian torsion. And so any significant, big aerobic exercise, inversions like Pilates, yoga, I would say you don't do. You're not going to get on an airplane on day 10 of stimulation and your retrieval's on, Friday. You're not traveling that, So I would say budget 2 weeks where you're here. You're in the beginning, if you have to leave for a quick work trip, that's fine. But really, you know, halfway through to the end, you kind of have to be in New York. Stress is a hard one. I think that stress affects everything in life. However, I've learned that to tell someone who's stressed to not be stressed out and it's just it doesn't work. You know, it doesn't help anything. I think the concept of mindfulness is really important. Whatever you can do as a person, whether it's this during this process or in your life in general, you know, whatever you can do to uh you know, reduce stress for yourself, I think is important, you know, whatever that is. For some people, it's sleep. For some people, it's going to acupuncture. Some people like to read. They like to exercise. They like to go out with friends. You should do all of those things for sure. Don't, you know, if you have a deadline and you're an accountant, you know, and the deadline is April 15th, I mean, don't extract, you know, the 14th, wait until after the 15th. Some people take supplements. We're fine with that. Some people do acupuncture. They do, you know, it's all good. So whatever you want to do that makes you feel good, you should do, is what I would say. So someone wrote here, if I have a cyst or an endometrioma, can I still egg freeze? Can I still do egg retrieval? Yeah, you can. So endometriosis doesn't go away. So if the patient has a stable, small/medium size endometrioma, just egg freeze. Or if you're doing fertility treatments, just do fertility treatments. We really don't want to operate on patients to take out endometriomas because the reality is it can just compromise the ovary and often the endometriosis comes back. There are some patients where it's sizable and it's really big or they're in a lot of pain, you know, and we make a decision to do the surgery. A non-endometrioma type cyst, like a simple cyst, sometimes does not go away. And as long as it does not put out hormones, we can stimulate and extract. There is something called a functional cyst, meaning the cyst that comes, puts out estrogen. That can, you know, delay your treatment. Eventually they go away. But if you had a functional cyst, we would not start that month. We just might wait the month and hopefully a lot of times it ends up going away. These simple cysts do come and go, you know, every 4 to 4 weeks or so. After the retrieval, you know, common sense, again, you know, you're having this procedure, you wouldn't run a marathon the next day. When you get the period a week later, you'll be very much back to normal and you can very much resume your normal life. But I always say, like, take it easy for a day or two afterwards. You can go to work. Most people go to work the day after. If you could get off and you want to relax at home, that's fine. But certainly the following day you can absolutely go to work. Airplane travel is okay. You know, I wouldn't go on an international flight, but you know, local travel is okay. But typically we would say no real heavy aerobic exercise till you get the period a week after the retrieval. Any sort of medications for anxiety or like mood stabilizer or depression, most of them are fine. So an SSRI is fine to stay on. The only medications that we're typically limiting now for egg freezing is, which is very, you know, it's common now, is the GLP-1s, right? So the Ozempic or the Mounjaro, you know, the weight loss medications. Anesthesia does not want you on those meds for 7 days pre-IV sedation, because when you're on the medications, I think, you know, most of us know this, or if you don't, we'll educate, is that it slows the gastric system down. And so the anesthesiologists do not want you to have a slowed gastric system when you are undergoing anesthesia, because it puts you at risk of aspirating. So for anyone that's on a GLP-1, they would stop it the day that they start their injections. But like, you know, Prozac or Lexapro or, you know, Zoloft are fine to be on. You do not need to be off of it. No, and so you know, when you come in for the initial evaluation, I mean, if I could write the book, you know, everyone would come in on day 1, 2, 3, 4, or 5 of their period for the baseline ultrasound. But honestly, most of us have been doing this long enough that it doesn't matter. You can draw an AMH at any time in your cycle. It doesn't need to be in the beginning. So you can make an appointment to see a doctor, honestly, at any time. We can tell by ultrasound how many follicles you have. And then Again, the AMH level in the blood, the anti-Müllerian hormone in the blood can be drawn at any time. So it does not matter when you come in for the initial evaluation. Someone on here, if I'm taking GI shots, I wonder if that's the GLP-1. So if you're taking those, you're not going to be on them. You're going to stop. The fertility shots are, by the way, it is just like it's the same needle. It's that small little tiny needle. One of them's on a pen. It's similar. So I don't know what medication this attendee is speaking about, but if it's the GLP-1, you would stop it. Oral meds are fine, like Pepcid, Prilosec. You can continue to take that with the fertility medications. And sure, for IBD, not for GLP, for IBD. I think you can stay on it. And again, any patient that comes in, we can really look at it. But if it's for IBD, I think you could stay on it. I do not believe you need to stop it. And it doesn't need to be timed with a fertility drug, so you could stay if you want it to be for convenience, that's fine. But the fertility meds that we give, we would typically say take in the morning and then take at night, between 5 and 8 at night. And then the others, take in the morning before work, as you get up. So I mean, I applaud you guys for coming on. If you have any questions, you can email me. My email is bmcavey@rmaliivf.com. If you have any, questions, you want to speak to me, if you want to see me, I see patients in Garden City. I'm on Long Island, but we could always do a Zoom. And again, you'll keep us posted. If you live in Westchester, Brooklyn, you want to see when the doc's there, everyone's great. It's like a family. We all speak to each other. So, but definitely, I encourage you to be seen, get your AMH drawn, and, really look at it as just a power move on behalf of yourself. It's for you. The eggs are for you. They're not for anybody else. You may not use them, and if that's the worst case, going forward, if you don't use them, that's your only regret. It's not a bad one. In terms of cost, I don't want to go into the cost because the labs, the different practices might have slightly different costs. It's all generally around the same. But wherever you end up being seen, we can give you the exact breakdown. Also, our anesthesiologists, some of them go through the insurance, some of them don't, or, so I don't want to get into specifics. In general, the amount for egg freezing is somewhere in I would say the $9,000 to $10,000 range to extract if you don't have insurance coverage. The medications, it depends on weight and your AMH. It can range probably, I don't know, maybe from $2,000 to $4,000 for meds. Sometimes patients have friends, that have gone through, or sisters that have gone through. You can always use if you can find unused meds, patients do it. There's all sorts of blogs, and sometimes that is helpful. There's also pharmaceutical discount programs. Specifically, there's one through Serrano, which sells Gonal F. It's called Compassionate Care. If you ever Google it, Compassionate Care Serrano, it will take you to a website. And so there are discount programs based on your income for the meds, but it still costs probably, a few thousand for the meds if you don't have coverage. So that's it. Keep me posted, guys. I hope everyone is doing well, and anything that comes up, feel free to reach out directly or to the practice. And I hope I helped somebody today with a little bit of knowledge, which knowledge is power, right? So I wish you all the best. Take care, guys. Take care. Bye-bye.